Well, welcome back. Carson, it's good to have you on the podcast today.
Yes, glad to be here.
So we've got Carson Boyer with us. You've been a clinician with us here at XCEL for, help me out.
Probably about a year and a half.
Okay, but prior to that, you had a 8 or a 12-week internship with us?
6 week.
6 week. It felt like 8 to 12.
I know. You're telling me.
I'm kidding. But no, this has been a long time coming. We've been trying to get this done for a while. So I think where I'd like to start, I want people to get to know you a little bit better. So tell us about yourself and kind of how you came into the PT world.
Yeah, so I'm from Quincy, born and raised. And I grew up, so I am one of the oldest of 4 girls. So I'm a twin, but I'm still the oldest. So
Your
I'm
poor
taking
dad.
that minute older. So I'm claiming.
Okay.
So we all grew up very close. So the youngest sister's 18 now. Sister right behind my twin and I'm going to butcher this, 23.
Okay.
She's about to turn 23 this month.
Okay.
29, 24. So all grew up very close. Grew up playing soccer all together. Yeah. And then starting with PT, I always knew I wanted to be in sports medicine and work with athletes. So mainly the first thing I wanted to do was athletic training. So I was fully committed to doing athletic training. I was going to go to Culver. And then after shadowing and listening to some of the athletic trainers, I kind of changed my mind a bit.
Yeah.
Nothing against the athletic training profession, but
No.
a lot of the main complaints was, it's great while you're young. You don't have any kids, family responsibilities. You can travel. You can stay late for the games. You can do the early morning Saturday practices. But once you get older, you have family and kids. It's not,
Yeah.
you
hard.
can't do that all the time. So in my head, I was like, well, shoot, I don't want to commit this much schooling, this much debt into something that I'm probably going to change my mind in later.
Yeah.
So a lot of the athletic trainers I spoke to and shadowed are also PTAs. So I just decided to go the PTA route. So did that, and then still finishing up some of my bachelor's for healthcare management online. So
Yeah. No, you've done a lot at a young age.
Yeah.
I think one of the biggest things that when you were here for your internship that impressed us was attention to detail. That was something that always, it's difficult. It's always kind of a crapshoot whenever we get a student here. And I remember, internships are not easy. You have, not only are you still in school, studying for exams, still having to have a life too, but you're here and you were with one of our best, KJ Whitaker.
yeah,
KJ Whitaker, in my opinion, is genius level. He probably won't like that I'm saying that, but
I agree.
that was a tough time, but you handled it really well, and that's quite frankly why you're here, because we wanted you here.
Well, I mean, sorry to cut you off, but
No.
to be honest too, so when we were trying to figure out our clinical locations, I knew I needed one more outpatient location, and I couldn't remember what clinic was here, so I didn't really know about XCEL.
Yeah.
And so when I was figuring it out, drove by, saw XCEL, I was like, okay, well, I need another outpatient clinic. I'll go here. I think, I don't know who I reached out to on Facebook, but I reached out to somebody on Facebook and was like, hey, do you guys take students? And
That might have
I
been
don't
me.
even think, yeah,
I don't
because
remember.
I don't think you guys were even open a year yet. So
Right.
I don't know if one of the first students, so it was very intimidating too for me because, before I get myself into something, I'm going to research and look at what I'm getting myself into. And so I did come across the podcast. There were a couple episodes posted before I started my clinical, and I was like, oh my gosh, there's just a bunch of men that work here. And I was terrified because I was like, well, they're all older men. I'm a 24-year-old girl. They're PTs. Right. I'm a PTA. So I was like, that's kind of intimidating to begin with. But getting into it, I knew KJ just from soccer growing up. His oldest son is the same age as me. So I was like, no, it'll be good. But I mean, from the first day, I think I pretty much felt at ease. It was, I think one of the first things KJ said to me before we started was, make mistakes and learn from them. And I think that was the biggest deal for me because I've always heard, don't be afraid to make mistakes, which is kind of I don't know if it's the defiance in me, was like, don't be afraid to make mistakes. It's like, well, I'm gonna be afraid. But with KJ, the way he worded it was kind of giving me permission to make mistakes, which was okay.
Well, and giving you permission to be yourself too.
Yeah.
Because we wouldn't want a student or anybody to be KJ or to be Riley or to be Michael or anybody. It's just like you got to figure that out for yourself a little bit.
Yeah.
There were some good days, there were some hard days, right? And that's part of the journey. You being an athlete, playing soccer, playing other sports throughout your life, how did that shape? You said you knew you wanted to be around athletes, but think about now. I mean, you do definitely work with a lot of athletes now, but that's also transitioned to pelvic floor therapy. It's transitioned to somebody who's had a total knee replacement. Was that a tough transition for you to go from, okay, I want to work with athletes, to now I'm working with, the 75-year-old who just needs to be able to get up out of their chair?
Yeah.
Can you talk about that a little bit?
Yeah. Actually, it's a complete 180. In school, they always told us that you'll go into it thinking you want to work with this specific population or work in this specific setting, but you'll find that you'll probably do a complete 180 with it, which in my case is true because I did want to work specifically with athletes. But right now, I mean, I do work with athletes. I enjoy it, but I think one of the first loves I had with physical therapy is neuro. I love neuro patients, so movement disorders, Parkinson's, anything along those lines.
Stroke.
Yeah, absolutely. Because I find that's where I can get the most creative with my exercises. Anything I prescribe them is I most oftentimes am going to combine something functional that they can't do with something cognitive to make it dual tasking, because that's what we all do in our everyday lives.
And you've quit, not to cut you off, but you've quickly, like we have a young patient right now, a 6-year-old who broke his arm, just doing some stuff. And to be straight with you, like I'm having a difficult time coming up with things not only to challenge him and get him better, but to also keep him engaged. And I've come to you multiple times and said, hey, give me some ideas here because I'm on the struggle bus right now. I don't know where to go and how can I get this kid, from point A to point B and have a normal, healthy life again. So that's also one strength that I've seen, especially in the past, I would say year with you, is you've gotten, to use your word, more creative with your interventions.
Yeah.
And you got to think outside the box a little bit. Has that been challenging for you, or where did that come from? Is it just from your athletic experience, or is it just YouTube, or where does that come from?
Honestly, it is, to be quite honest, I mean, when I was a student, I worked with you a little bit too. And I always kind of found it interesting because you'd go into a session with someone you either have seen them a couple times or haven't seen them, and you tell me, you're like, I have no idea what I'm going to do yet. And I'm like, what? What do you mean you have no idea? Because in school, they make you sit there and they're like, all right, what exercises are we going to do for this person that has this diagnosis? So you're almost like trained to think in a way where I have to do this, 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 and this. But so that kind of blew my mind when you said that. But as I'm working in this profession, I kind of think it's like, I mean, it never goes the way that you think it's going to go. So I tend to think better on the spot. And I mean, when I make my exercises or when I give something that for a neuro patient is maybe a little more creative or a little more functional with dual tasking, I first start with the function. I'm like, what are they missing? What do we need to address?
What do they need to be able to do?
Yeah, because I mean, there are a bunch of different ways. If someone can't go upstairs or stand up from a chair, there are a bunch of different ways to work that. That isn't just repetitively sitting in a chair.
Right.
And I mean, it's kind of boring too. I'm not going to sit there and watch you stand up and down 20 times.
That's a big part of it, is you got to keep the patient engaged, right? I think you've done a really good job of that. And, maybe this isn't the right term or the right phrase, but cookie cutter. Yeah. I think there's a lot of, we're going to have a guest on the podcast here in a few weeks who he talks about that. That's one of the downfalls of physical therapy is, you go to a session for 20 to 30 minutes, in a lot of cases, and it's cookie cutter. It's long arc quad, it's hamstring curls, it's sit to stands, and those things can definitely be of value. Right. But there's a level of engagement that you got to, I think, sometimes give the patient an experience too, to keep them involved and engaged in the process, right? I think I've seen growth, from that for you, especially in the last year. I want to transition here just real quick, if you don't mind. pelvic floor therapy, and I'm saying that loosely kind of as a general term because it's a very broad. This is definitely one of the areas where you are interested in. You've learned a ton. You've gone and got certifications. You just put on a seminar, basically, was it last week or the week before?
Yeah, a week ago today.
At the Croc Center here in town. Did a great job, had a great turnout. We had stuff given away that was gone in like 5 minutes, I think, if I recall correctly. They had a great turnout. But what is it, number one? And number two, well, start with that first. What is pelvic floor therapy?
So pelvic floor therapy is basically addressing the deep layer of your pelvic floor and your core. So there are multiple layers, but the ones we address the most is the deep layer. So that's what connects your core to your pelvic floor. So whether it's incontinence or chronic pelvic pain, postpartum, pregnancy, anything, you'll always have some sort of distress on your pelvic floor. So that could also, menopause with age. It's just, your pelvic floor is just like any other muscle. So you can, sit and do a bicep curl 20 times, train it, you'll get stronger. You can see it. You can see your bicep grow. Pelvic floor is a little bit harder because you can't see it.
Yeah.
So you really have to learn to kind of get in tune with your body, knowing you're training the pelvic floor correctly, because that's your support system. They speak of it kind of like a hammock. So if you have a hammock and you have your pelvic floor organs, so for women, your uterus, your bladder, your rectum, men, bladder, prostate, rectum, they're sitting on a hammock, which is your pelvic floor. So if that is not strong, it cannot support those organs, which is what leads to the dysfunction with incontinence, pelvic pain, anything along those lines. That's actually the best
description. Now, I've not done a lot of research into this space, but that's probably the best description. That's treat me like a kindergartner or speak to me like that was something I don't know a lot about. What you mentioned incontinence, but what other problems do people typically see if they have a weak pelvic floor?
Yep. So weak pelvic floor. So one, it's the floor of your core. So if you have a weak pelvic floor, you probably have a weak core. So you'll probably have some postural instability. The course that I took,
pain, right?
Yes, low back pain. The course that I took specifically was for orthopedic clinicians. So there are a lot of orthopedic ties that you can tie into it. So anything hip pain, low back pain, especially after it doesn't even just have to be directly pelvic floor to start with. Like you could go in, have a low back surgery, a total hip replacement, whatever it is. It could be from the pain medication that you get that you're constipated. It could be from maybe that low back surgery, close to the sacral nerves. It could mess with something along those lines that leads to incontinence. So it's not necessarily something you always prepare for, but it's a surgery that you're like, oh shoot, now I have this problem. How do I address it? And not a lot of people know about that. So there are a bunch of different avenues that you could go down with it. So,
and it's tough to talk about for a lot of people.
It is.
It's not, let's be honest. If I have incontinence as a 37-year-old guy, it's probably not the first topic I'm going to bring up at while I'm having a beer.
Yeah, right.
There's a little bit of a stigma to it as well, I feel like. At least, again, as an outsider not knowing a whole lot about it, it's kind of hush-hush. It's not something you talk about a whole lot, but it's pretty important. I feel like it's a growing part of physical therapy as well. So let me see. I've already asked, what are some common symptoms that people can experience from a weak pelvic floor or core? What are some, maybe like if there was one thing, two, three things, like intervention-wise, or when I say intervention, like an exercise that somebody could do if they suspect that this is an issue, what could they do to make it better? Like a pelvic tilt, or what kinds of things would they do?
Yeah, so I'm sure everyone's probably heard of Kegels, which, they're great. It's basic, if you haven't, just a contraction of your pelvic floor. But it's also pretty hard to, if you've never done it or have never really thought of your pelvic floor, you're not going to know how to do that. So it's not something, like I won't tell somebody to go and do Kegels unless I'm there to instruct them the first couple times. So I would say, which is why, working with KJ has also been so beneficial, because breathing is very important.
PRI, posture restoration.
So your diaphragm works in connection with your pelvic floor. So it's kind of like a pistoning effect. So your diaphragm moves up, your pelvic floor moves up, your diaphragm moves down, your pelvic floor moves down.
Okay.
So, when you're inhaling, and you're expanding through your diaphragm, and your pelvic floor is dropping, your diaphragm is dropping. When you're exhaling, everything's lifting, it's contracting. So your pelvic floor moves up, your diaphragm moves up. And so that's what's also really important about posture, because if you don't have that correct posture and you don't have the alignment with your diaphragm above your pelvic floor, they're not going to work together. And
synergistically at all.
That piston effect is no longer there. So I think, long answer, I'd say breathing and just becoming more aware of posture, core coordination. And then once you get that down, that's when I'll probably start the pelvic floor contractions or the Kegels.
Right. Talk about real quick, maybe as we start to wrap this up, I want you to talk a little about, because there's both internal pelvic floor therapy and external. And it's like, well, you hear that word internal, it's like, oh, heck no, I am not doing that.
Yeah.
And you don't always have to do that. In fact, a lot of times you don't have to do that, correct me if I'm wrong, to get a beneficial impact from external pelvic floor. So talk about that, and also maybe to wrap up, talk about if somebody suspects that they have this, what are the next steps for them? They can come in here for a free consultation, both by you and KJ, in our clinic anyway, Jalen Francisco in Hannibal, Missouri. But talk about those two aspects a little bit. But it doesn't always have to be the internal pelvic floor therapy, and like what the next steps would be if they suspect maybe this is something they need to get a consultation on.
Yep. So the course I took was specific for external techniques. So like you said, internal is always an option, but you definitely don't have to have that. And external, pretty much what they taught us is how to assess pelvic floor function and contraction externally. So you can do that internally. You'll get a more accurate assessment. But there's honestly not even to say valid, hesitant, but it's hard to assess pelvic floor muscle function internally, because you can't just take a muscle force gauge to the pelvic floor. You can't do that. So it's hard to assess anyway. But I say you don't need it, because there's been plenty of times in the clinic here where someone's come up to me and said, like, Michael had a patient not too long ago where she had a total hip replacement, and she was dealing with bladder symptoms where she felt like she was not voiding all the way. So she felt like she was always going to the bathroom. And, when you have a full bladder, you're not voiding all the way. You also increase pelvic pressure and low back pain. So addressed it. And first, when I talked to somebody about it, they know the Kegels, they know the core exercise. She's already doing a lot of the right exercises with it being a total hip replacement. So I will ask, okay, so what is your water intake? How much water do you drink a day? Do you have any bladder irritants? So bladder irritants are anything like caffeine. Right. It's essentially like an allergy to the bladder. So when you have an allergic reaction with pollen, you sneeze and your eyes itch, it's just an irritation, increase in inflammation. So if you have that same thing happen to your bladder, that's where a lot of the symptoms come from. Whether that's incontinence or whatever it is, but talking to her about that. Also, toilet posturing is a very big thing. So if anyone's ever heard of a Squatty Potty, that helps get your knees above 90 degrees. And then also breathing while you are going to the bathroom, so you're not pushing or straining really hard. And then honestly, too, if for avoiding dysfunction like that, I always say just sit an extra 30 seconds on the toilet, completely relax, breathe into your belly.
Give it time.
Yeah, and make sure, because you'll probably find that you still do have to go. And then, once they complete that, if you get the urge to go to the bathroom again, maybe wait a little bit, see, do I have to go, or is this just my brain telling me my bladder needs to go because of the dysfunction that I've gone every 2 hours on the dot?
Right.
So spoke with her one time, and she came back the next week, and she implemented those things, and she felt a lot better. So it's a lot of the times you don't even really have to touch anybody. And that's what I think is so great about pelvic floor, is nobody knows a lot about it, but there's so much knowledge and information that needs to be shared for people to understand it a little better and implement.
In the history of the world, we've never had more access to information than what we do today. So that's what I'm hopeful for, is that this will kind of spur on some conversations for people that maybe they know they've got this, but they haven't addressed it. Yeah. Because there's, again, the stigma to it, that maybe they have some concerns or fears that they have to have an internal examination. That's not always the case, as you mentioned. But little hinges swing big doors. It's one of my favorite sayings.
Mm-hmm.
Small incremental things can have a big impact, especially if you do them on a consistent basis, to your point.
Yeah.
So no, that's actually, those descriptions were really helpful even for me. I know a little bit. I know enough to be dangerous, but not good enough to treat it. You know?
Well, and I mean, to kind of like your last question, I think what symptoms to look for.
Yeah.
To be pretty simple. Well, I mean, if you've had children, I think almost in a way, just like we would do prehab for a total knee, total hip, whatever it is, it almost should be looked at like if you are pregnant, expecting a child, we should start probably training your pelvic floor now, not only to prepare for childbirth, but for after, because a lot of the effects, happen after. Your pelvic floor just went through a traumatic event, essentially. So there's a lot that needs to be worked on there and trained. So noticing the symptoms, preparing, I guess, which I think I would like physical therapy to look more towards is preventing and not as much just treating.
Yeah.
So preventing these dysfunctions, whether that's pregnancy, postpartum, and then looking for with age, menopause, naturally your hormones are affected. So if you struggle with any incontinence there, whether that's urinary or fecal, it doesn't matter. Looking for those things, urge, voiding dysfunction, anything like that.
Yeah. No, it's a good topic, but again, I bet if every 10 people that just we randomly lined up people, I don't know what the stats say, but I bet half of them have issues.
Yeah.
If not more. So it's a big challenge and it's a big issue, and it doesn't need to be on public display. Like there's ways that it can be addressed very discreetly and respectfully. So,
yeah, absolutely.
Carson, thanks for coming on. Hopefully this has been fun for you. And if you have any questions, please reach out to us, reach out to Carson, especially if it's in the pelvic floor space. She's awesome. Jillian Francisco, one of our PTs in Hannibal, Missouri, also really does a great job with clinicians and patients in this space as well. So please reach out if you have any questions, and we'll see you next time.